a couple of weeks ago, a month ago as well. And in that situation, I was just spitting information at you. Today, I thought I would do the reverse and just let you ask questions of me. I have questions for you in case there's awkward silence, but really, I wanted this to be more of a conversation and give you some free space and a safe space to ask whatever questions you've got about antibiotics. As I think I mentioned last time, we know scientifically, because we've measured it, we know that when people come into internal medicine residency, even the best residency like UW, there's still a lot of questions about antibiotics. That's why you're being residents, right? So this is intended to be a time for you to ask questions about general ID. That's what I happen to do. Although I'm happy to entertain other questions as well. I'm going to talk about STIs, so I can do that. But really to have those bread and butter issues that you will encounter inpatient on your rotations, whether it's ward or ICU, but also in the clinic. So I know you guys keep continuity clinic. ID comes up every single time. And I'm happy to talk about that also. I see this as a session through two lenses. The first is to impart knowledge and practice elevation to you. You are my focus, but it also occurs to me that you are now the teacher of your own medical students. And I remember when I was starting an internship, it was like a head kick, like, oh my God, now I have my own students. I thought I was a student. So that's a huge source of stress, I think, for a lot of new residents that they have to teach the next generation, as Star Trek says. So part of today will be also giving you, if you'd like, coaching tips and such around teaching the students, because they will ask you all these same questions you're about to ask me. So you will now have the answers. And when it comes to the teaching side, my only advice is to really develop and own your own scripts. And what I mean by that is one of our most masterful teachers was called Steve McGee at our Seattle VA. He's now retired. It's a heartbreaker. I guess he's earned it, but he was just the best. You would have loved Steve. And he would talk about teaching in internal medicine, which he attended on the wards virtually all the time. And he said, look, the best teachers have their script. And it means that the student will ask a question about cellulitis or about diarrhea, and there'll be these 5 teaching pearls, in some cases only 3 teaching pearls that he would have for each of those scenarios, and he would internalize them. And it doesn't mean that you give the same robo talk every time, but you would have those core elements that you were totally settled on and happy about, and then you could have a conversation. And that was very liberating to me, because to me, the idea of having a teaching script sounds so canned and corny and hokey, but it works. And having those core teaching elements in mind, just at your fingertips. I think it's true for issues ID. It is true for any of the common things you'll see in medicine, whether it's related to endocrine, cardiology. God help you go into cardiology. It's a pump. It has 4 chambers. What the hell? But people do it, and so you should know about that pump too, etc. So let's talk about that too. I had a similar question for all of you. Um, for example, I think Gabby had kindly asked you to do our online teaching module for antimicrobial stewardship. I know some of you probably have. Most of you probably have not yet done because you're busy being new doctors. But for somebody who has, and I will also check the chat. By the way, I am versatile. I can take your written or spoken word. I really prefer spoken, but written is okay. If you are, long-time listener, first-time caller, that kind of thing, you can chat me up here too. But thinking about those 4 cases that we had in the curriculum, I'm looking for 3 take-home points that you would have about antibiotic use or prevention or care or diagnostics. 3 take-home points on each of those cases. One of the cases was related to a catheter-associated UTI. So let me ask you about that. What are if just start putting them out there? What are some core teaching elements that you have in CAUTI, what we say for cath-associated UTI? And I will not just call on the brave souls who are on camera. You guys are awesome. Shaka sign to you. But everybody is fair game for this one. Rima, exactly right. Don't treat without symptoms. Damn right. We treat patients, not lab results, right? This is one of the recurring themes of internal medicine. So I think that's true. I would suggest to you that I wouldn't even call that a UTI. A patient without symptoms, what do we call that? Asymptomatic bacteriuria. So that difference between UTI and ASB, or what I call ABU, but we're supposed to call it ASB. UTI symptoms. The patient is paying a price. It could be fever, it could be pain, urgency. Could be leukocytosis. God help us, it could be sepsis, right? Very different from ASB. And as I've said before, you only know three things in life: death, taxes, and a positive Foley catheter culture. I mean, every single day the Foley is in place. You go up in 5 to 10% of the likelihood of getting something to grow. Urine is a great culture medium. So eventually the bag, the circuit, and the tube will become colonized, right? You look for bugs, you'll find them, but that does not mean that you treat. So thank you for that. I appreciate it. And the reason that I raise that with you, I think it's a great way to start, is that you will find, I think, that here at UW, we really have, I mean this in all sincerity, they're not even on the call, so I'm telling you the truth. We have the best nurses around, and they're just so, so good. They're very thoughtful, they're very savvy, and they understand what diagnostic stewardship is about. So they're not just going to call you to say, ooh, there's a cloudy urine, I give this person levofloxacin. It doesn't work that way here at UW. But you will encounter this issue where a family member, a healthcare provider at home, or sometimes, yes, within the hospital, might say, hey, that urine smells bad. Or I don't like the cloudy look of that urine. That urine's looking more concentrated and dark. I just send it for UA and culture. We really try not to do that. The testing in your patient should come from you as their physician and not from the nurse. It's not to disrespect the nurses, it's that I want you to have that conversation with that person and really have a conversation, because they may be right. They smell pee for a living. I mean, they do have a sense of what is right and wrong in your patient. And so respecting that clinical savvy is important, but yeah, not reflexing to just run a culture, because it will indeed turn positive. Okay, so thoughtfulness. That was amazing. Thank you, Rima. Thoughtfulness between ASB and UTI. Well done. Two more things for catheter associated UTI. Or you could give me more, that's fine, but at least two more things. Yeah, okay, thank you. So both Tinny and Michael, you guys are awesome. So let's talk about this. If you think your patient does have UTI, then collecting that specimen in the proper way. And by the way, when's the last time you collected a urine specimen or any specimen? The bad old days when I was a student, we had to do some of our own blood cultures. It was so, so flippin' terrible. So you're not going to do this testing, right? You will do your own thoracentesis and paracentesis and LP. That's different. But for stuff like this, it is the nurse or the patient care technician. We have PCTs here at Montlake. They're the ones who are going to do it. So I think, Tinny, you're correct. We really want to make sure that this is collected in the proper way if you choose to collect. For a Foley catheter in particular, there's a port which is proximal to the collection bag. That should be scrubbed with ethanol or povidone iodine or CHG or something. Ethanol is usually the way they will do it so that it doesn't degrade the material that's there at the port. It's basically a lure lock. And just like you would scrub for an IV or a PICC, so too with the lure. So really encourage that to happen properly, but never from the bag and never ever from that little green hose that just dangly doos down and touches the floor. I mean, that's a horrible idea. So yes, making sure that it's collected properly is key. You will unlikely be there when that is happening. So what I'm getting from you, Tinny, is this very nice idea. Hey, if it's an unexpected result, can we go back and either talk to the person who did it or consider repeating it? And you can indeed do it yourself. If in doubt, do it yourself and just make sure that you've prepped that area, allow the ethanol to dry, and then take a sterile syringe with the lure lock and pull it back. Anything less than that, anything from the bag, I am instantly super skeptical about, put it that way. So I thought that was terrific. And then Michael, I love this because that really goes to the tip top of our whole list. So the first thing I want to do, which is, does the patient need a Foley at all? When he was an internal medicine fellow, Dr. Sanjay here at UW, Sanjay Saint, now chief of medicine at Michigan VA, but he did a study on this exact topic at the Seattle VA. It's a great study, I think from around 1995 or so. And what he did basically was to interview medical students, medical interns, medicine residents, and medicine attendings at the VA in a room with no windows or something. And he would just go through the list and say, who on this list has a Foley catheter? And the more senior the person was, the less likely they were to have any clue who had a Foley catheter. Like the students and the interns were all about it. The attendings did not have a flippin' clue. So Sanjay calls it WTF. Where's the Foley? Like it's just that often he would look for an order to see where the Foley had come from. Half the time there was no order. It was the immaculate intubation of the bladder. And so this needs to stop. And I think it has. In recent decades, you guys are now benefits of the mistakes that my old folks have made, we're trying to be more savvy about who gets a Foley catheter. So this should be part of your checklist every day on rounds, lines, tubes, and drains. Who needs a catheter, and if we can get it out, can we please do so? It's not only for catheter-associated UTI, but remember, these patients are also, in the case of people living with a prostate, prostatitis is a sequel as well of indwelling Foley catheterization as well, and that can even lead to prostate abscess. These are painful to deal with. So yeah, being savvy about who does and does not need a Foley catheter is smart. So thanks for being thoughtful about that. The longer the catheter is in place, the greater the chance of colonization, the greater chance of colonization, the greater chance of infection. So you guys have met my criteria, and before I move on to the next infection, I'll just give you one more pearl. I have many pearls about UTI, but one of them is this. The presence of a Foley catheter is required for catheter-associated UTI, but it's not sufficient. What you need is trauma, friction. It's super duper important when you go through that daily list. If you're looking at the catheter, let's say you need to keep it in for whatever reason, good reason, you've chosen to keep the Foley in place, make sure that the Foley care is proper. What I mean by Foley care is all those things that I think you've internalized. The bag cannot touch the floor, and it will. These beds, these robo beds that move up and down, you push the button, you're listening to the heart, and oops, sorry, I made the bed go up and down. That's going to put the Foley bag on the floor. That is an independent risk factor for progression to UTI. And these stupid beds are just not made with Foley catheters in place. So that's one thing. If you see it on the floor, please fix it. Number two, no blind loops so that the patient, you want it to be a clear path of gravity so that the urine can get out of the bladder. That's key. And then number three, trauma. The ultimate trauma is, gets caught under the wheelchair when someone's going for a chest x-ray and they auto-terp themselves. That hurts. But it can be more subtle. We really need to make sure that the catheter is carefully fixed to the body. And good nursing practice is to rotate sites. Right lower quadrant, left lower quadrant, right thigh, left thigh. And that this catheter moves so that there's a little bit of slack between these anchor sites on the body and the entry into the body. Whether it's male or female patient, doesn't matter. What we don't want is for the balloon to rub the trigone of the bladder. When that happens, transitional epithelium is stripped away, and that's when you get in trouble. They've all got asymptomatic bacteriuria. Now the transitional epithelium is rubbed away, and that's when you get invasion, adherence to the bladder wall, and you're off to the races with cystitis. So it's a subtle thing, it's a nursing thing, it's not a medical doctor thing, and yet we have an opportunity, I think, to lead on this topic. So really talk with your nurses and say, hey, what's your Foley fixation strategy? How's it working for this person? They may have a colostomy in place. The nurse says, God, I can't fix it to the belly because there's just poop everywhere. It's not going to work. This person may be allergic to the tape. You may have to come up with an alternative way that involves, a cloth strip that goes around the thigh rather than a glued-on anchor. Be innovative this way. You should improvise this way and really focus on that. Are there other questions about catheter-associated UTI? Or teaching pearls that I missed? Oh my God, I'm sure I missed a bunch.
Hey, I had a question. This is Olivia.
Thanks, Olivia.
I was wondering if the patient does not reliably report symptoms like altered mental status or nonverbal, and their UA comes out like with nitrates and leukocyte esterase, do you treat that or do you not?
Yeah, thank you. I just love, love, love that question. It's so good because forever the teaching, at least when I was in med school residency, and what I have taught, I am so embarrassed, I have taught this to generations of people, is that delirium in the setting of a Foley catheter should be considered UTI until proven otherwise. Thank goodness people much smarter than me have actually looked at this issue. So we have multiple studies and now society guidelines from both IDSA and the American Urological Association and the American Nursing Home Society. There's a whole society of nursing homes. It's a trap, like they say in Star Wars. It's a trap. Be careful. Olivia, this may indeed be what's going on. And in a patient who is septic, where you're looking at their entire portfolio of vital signs and labs, this could very well be a source. Urosepsis is a thing, especially when the catheter is not carefully fixed to the thigh. But having said so, it is uncommonly the case. There is almost always an alternative explanation for their delirium. So I'm talking about for new onset delirium in a hospitalized patient. This is almost always meds. And if it's not meds, then it's meds, and then it could be meds. Then meds, then UTI, then meds. So think about medications and that day-night shift that we see for people coming out of ICU. Why do I raise this? Because we have overtreated these patients, which may paradoxically, perversely make things worse with respect to their delirium because of side effects of medications, our antibiotics that give them C. diff, and now they're delirious and shitting up the walls brown. So for a patient who, I think that's easier. For new onset delirium, it is very uncommonly UTI. For the patient who comes in with baseline dementia and delirium from usually a nursing home, LTAC, some other Death Star, these are much tougher cases because you just can't get that history. And you're doing veterinary medicine, or what I call pediatric medicine, which just scares the hell out of me. Where's my history? I can't get it. Talking in that situation, I think really talking with the nursing team, physician team, if you can, that knows that patient, family members, what's the change been? If so, you may end up going down the pathway of UTI because, as you say, they may have nitrites, they may have leukocyte esterase. They've all got, I got leukocyte esterase right now. Everybody's got a trace LE, right? But it's that nitrite that you're looking for. You're looking for a large number of white cells, positive culture. You may end up having to treat that person. If you do, please make sure that in your soul you feel like, number one, you've gone through the list of other possibilities, medication, stroke, all the things that can cause acute on chronic altered mental status. And number two, limit it to a short duration. And finally, make sure that you change out the Foley catheter so you can try to break that cycle. UTI is real in these cases. It's not that you should never treat, it's just that you should think about other alternatives at the same time. It's a great question, Olivia. Okay, let's move on to our next
Can I
topic.
jump in
Oh, yeah.
so quickly,
Yeah, please.
Paul?
Yeah.
I think one of the other pearls that I've learned over time from Paul and others in that situation, Olivia, is the importance of really watching for improvement in your patient, right? You'll hear this all the time in morning report. It's almost always okay to give that first dose of antibiotics. The question is, do you continue them or pull back? This is a situation where you're treating somebody almost sort of empirically without a lot of great data to guide you. And if this is delirium or dementia and they're being brought in for some reason, you want to see that reason improve on your antibiotics. Otherwise, you're likely treating the wrong thing and you can stop the antibiotics and focus on something else. Is that fair, Paul?
It's not only fair, it's perfect.
Okay.
And remember, the watchword in general in ID, I think Gabby will agree, is that less is more. Shorter courses are better. And even in cath-associated UTI, treating for just a few days is appropriate. Treating for pyelonephritis, this is inflammation and bugs up in your kidney meat. We do that for 7 days, right? So for cystitis, it should just be a much shorter course depending on, which drug you have chosen. In fosfomycin, it's a single dose. In trim sulfa can be, 5 days, and nitro 5 days. So these shorter courses are good. And I just want to put that out there as one of our key tenets of good stewardship, different from the way I was taught. The way I was taught was that longer is better so that you don't create resistance. This is backwards and incorrect, right? The longer you put a selective pressure on that germ population, the more resistance that you'll see. So typically shorter is more. And as you'll find, I think as you look through our Occam guidelines, we are giving you typical durations for each of those syndromes on the phone app that you guys have. And so that's a good way to start as well. Love it. Okay, another catheter-associated issue, which you will see in your practice, a catheter-associated bloodstream infection, CABC. We see catheter-associated bloodstream infections not only in the community, so many people running around with IV access, but also in our hospital as well. We take them seriously. They can be deadly if we mismanage them. So I'd love to hear from this amazing team. Let's get 3 take-home pearls about catheter-associated bloodstream infection. And Michael, you get a pass. If you want to just submit that same one again, that's all good. Right, so is the catheter necessary at all? I'll give you that one as a freebie. Fine. This is one of the fundamental things that we see in our patients with catheter-associated bloodstream infection, that we sort of wish they didn't have that catheter in the first place. And so very analogous to what we talked about with urinary catheters, so true bloodstream catheters. Do they need to have that line there at all? You will inherit patients who come in from the community with long-term indwelling central access. This could be for dialysis. This could be for TPN. This could be for chemotherapy. This could be for, in usual cases, people need IV rehydration. Why they can't drink water, I can't tell you, but this happens, right, supposedly. Maybe they need to get frequent courses of antibiotics because of their immune system being shot. So you're in a tough spot when you're inheriting these people because you want that catheter out of there. And there's going to be pressure. Sometimes there may be pressure from people on the outside who say, whatever you do, for the love of Pete, don't remove their central venous catheter. So, which is usually the wrong answer. So thinking about that, how would you determine whether a catheter can be removed, should be removed, or might not need to be removed? Yeah, Noah, love this. Great. So Tinny says, let's culture the lumens, culture them all up. And Noah says, yeah, we can get valuable information from collecting blood cultures from a central catheter and peripheral simultaneously. So I love this. And when it comes to, I think the pearl that you're getting at is when it comes to catheter-associated bloodstream infections, there's different flavors, right? There's a luminitis, as Tinney says, let's look at the lumen. Is this a problem on the inside of the catheter? But there's also tracheitis. So when you're looking at these patients, you need to understand it. Do they have pus coming out from around the catheter? A redness is, if it's a tunnel catheter, is there a red track? That's what I call an outside to inside infection. That's something from the exterior world, usually staph, sometimes strep, even shower water. Pseudomonas can do this, but it's gone up all around the surface of the catheter. Those lines must go straight up. If it's just the tiniest bit of pus just at the distal portion of a cuffed catheter, that's a special subset within hemodialysis because they do have a cuff. The cuff is a rough little olive-shaped blop that sits right near the end, and that grows into the skin. So for mild cases that are not blood culture positive, if it's just a little bit of pus and there is a cuff, we can give short course of orals. Otherwise, for a tracheitis or pus coming out of the line, it must go. If it's a PIC with a red exit site, it must go as well, period. And I'm a super flexible person in my life and in my practice, but these are pretty straightforward. We must remove those lines. That's a difference. Why? Because you can't get good source control. The bugs are forming a biofilm on the surface of the catheter. You could treat them with antibiotics, but it's going to come roaring back. So we usually get rid of those lines. If it's in the bloodstream alone, which presumably happens outside to in because of suboptimal technique with scrubbing the hub before the site is accessed, etc., then it's a bit more of a debate. And I think what you're getting at here, Noah, is just because you cultured that central line doesn't mean it's infected. What if there's an infected toe or some other focus that's led to bacteremia, and now you're just, blaming the catheter because they have a catheter? For patients with bloodstream infections and a catheter, it's usually the catheter, but not always. And so this nice technique you've talked about, I think, is smart. Let's draw a peripheral culture simultaneously with a central culture and see what happens. If the central culture is positive, the peripheral is negative, it's probably the central one. It's probably a line issue. Number two, you can also look to see how much time it takes. If they both turn positive, but the peripheral culture takes 5 hours longer than the central culture, that central culture had a bigger inoculum. It's probably the central culture. So the time to positivity can give you this information. You have medicine that's not published in EPIC, but it's in the lab, and so you can always call and ask for that. If you find yourself calling to ask for a differential time to positivity, please consult ID. This is the kind of thing we're very happy to help with. We're good at helping to adjudicate lines, and we will not just say pull the line. My fellows will often say that, but they won't always say that. We're trying to be very thoughtful about the whole picture and the pain and suffering it would go through if we actually do have to remove a line. And finally, you have another technique that I also like a lot, which is the quantitative culture. You can order blood culture quants, not only peripheral and central, but peripheral and central plus quantitation. Quantitation is a regular blood culture, and then there's a yellow top tube that's sent in addition to the blood culture tubes. The yellow top is poured into hot molten agar in the lab, solid medium, and that allows the technologist to actually count the number of CFUs. More than 100 CFUs per ml of blood, that's your problem. It is central line. And if you have both positive, but it's double or more from the central than the peripheral, you really need to get rid of that central line as well. So I think these techniques are there. I think it's good to be thoughtful about this. You should recognize that even if you find that you do have a lumen infection, you may still be able to save that site. And I just want to put that out there for you. This is another pearl. For patients living with hemodialysis, the line is cheap. The site is precious. And every time that ID tells you to remove the line, give a holiday, and then come back in with a fresh stick in 2 weeks, that's a risk for stenosis, that's a risk for clot, that's a risk for injury, that's a risk for infection. So what we do embrace in dialysis for patients who are going to keep needing dialysis is that for patients where we know the right blood culture is being treated, so it's usually coag negative staph or enterococcus, Staph aureus is exceptional. We'll still usually remove the IV for Staph aureus because it's such a rapacious apex carnivorous predator. But for coag-negative staph, enterococcus, what we can do is lose the track, but keep that central venous site. And the interventional radiologist can do a guide wire exchange of these lines in certain cases. And I love that. It's been studied by Dr. Mike Allen and others at Brown. This almost always works. It's very safe. You'd think it's horrifying. You're putting a ramrod down the lumen, they're going to shower their lungs with septic pulmonary emboli. No, they've been on the right bug juice for at least 48 hours. They still need the line. We can do these guide wire exchanges, and that just saves the patient this risk and pain and hassle of having to undergo a fresh Seldinger or IR stick. So the point is we have options. And just because you've diagnosed somebody with a luminitis doesn't mean that they are doomed. Talk with ID. We're happy to help walk through that process. Finally, again, just as was analogous to the urinary catheter story, site care. Really making sure that the site is kept clean and dry. Here at UW Medicine, we will apply a chlorhexidine device to the surface of the skin at the exit site. In outpatient use, that's called the 3M Bio Patch. Looks like a little round circle patch. The blue side goes up, blue to the sky. That leaches out CHG over a week. On the inpatient side, we use usually a little gel slab. You'll see a little brown, looks like a butter pat, but you can see through it. That's gelatin, but it has CHG in it as well. We're trying to just literally coat the skin with soap all the time. Patient gets it dirty, taking a shower, they need to have a nurse redo the entire, dressing the entire site as well. This prevents those outside to inside surface infections. When it comes to the lumen, it's all about site care. And if you see somebody who's in a rush or forgetting to really scrub the clave carefully with alcohol, we use the little green hub, we call the site right, where you'll see a little strip of silver devices with little green dots. Those are alcohol impregnated caps. Take one of those off, scrub it for 30 seconds, let it dry, and then access the hub. And if somebody's really in a rush and they're missing this, you can privately and respectfully, in just a friendly way, say, hey, Dr. Pottinger told me I needed to wait 30 seconds before I access that site. Blame it on me. That way you won't have any conflict with that nurse rushing through their process. Other questions about cath-associated bloodstream infections? Or pearls that I missed? I'm sure I missed a bunch. Okay, well done. What else have we got? Let's see, I'm thinking about that curriculum. Ooh, I think we had some pneumonia in there. I think we had a ventilator-associated pneumonia. So if you're in ICU and you're thinking about VAP, sometimes we call it vent-associated pneumonia. I'm going to put this in a broader category. Let's just talk about hospital-acquired pneumonia, HCAP, or healthcare-associated pneumonia. It goes by many different subgenres. But somebody who comes in with lungs that are okay, and now their lungs are not okay. I would love to hear from the group 3 pearls or questions. By the way, you don't just have to teach me. You can ask questions as well about someone who's acquiring an infection of their lungs in healthcare. I'm thinking about prevention. I'm thinking about diagnosis. I'm thinking about treatment. Ah, Lily. Okay. Can we talk more about the NARS MRSA swab? I could talk all day about the NARS MRSA swab. But Lily, because you are, and how much is the threat of Legionella right now? Okay, let me answer both those. These are great questions. Does anybody else feel comfortable answering Lily's question? And Lily, you can answer it yourself as well. What do you mean by the MRSA swab? Clarify for your friends, and then I'll give you the answer.
So I know, at least at Harborview, everybody who gets hospitalized gets surveillance MRSA swab that's taken from the NARS. And I was taught that the study that looked at it was all VA patients, and it's like something crazy, like 98% sensitive in kind of making sure that the pneumonia isn't from MRSA, and also the soft tissue infection is not from MRSA. But I was also told to kind of like take that data with a grain of salt in Harborview patients, because the study was done with all VA patients, so it might not be generalizable to all patients that we take care of. So I just wanted to kind of get your thoughts on like how you would then use that information to treat different patient populations.
I love it. It's great. So there's a wonderful paper, perfect, Lily. there's a wonderful series of papers on this very topic. What is the negative predictive value of having a positive swab of the nose with respect to other sites? I'm thinking pneumonia because, well, it's part of the airway, it's connected to the nose, but actually, as you point out, Lily, there are information about intra-abdominal infections, skin and soft tissue infections, urinary infections, bloodstream infections. So the largest data set is a beautiful one. It does come from VA, the nationwide VA system. And in that paper, the negative predictive value of a nasal swab, in other words, you swab the nose, there's no MRSA, but the patient does get a healthcare associated pneumonia. About 98.5% of the time, that means it's not going to be a MRSA pneumonia. So, first of all, somebody is in that group once in a while. The nose does not know. But second of all, that's a huge, I mean, there's very few things in medicine that have such a strong negative predictive value. Because of this concern around does VA really translate to Harborview and elsewhere, yep, we've repeated that study at Harborview. As you know, because there's a full-time FTE of one nurse who has a little cart that runs around from room to room, they bronch everybody at Harborview. Different from UW. They don't bronch just about everybody. At Harborview, they really do, and it's great because we have all this high-quality micro data. Same results. I beg your pardon. I think in the Harborview paper it was 95%, so pert darn close. That does seem to be roughly translatable. So what I would say is, first of all, why do we look in the nose at all? It's because of a law that was passed in the state of Washington in 2010 by Republican lawmakers in response to an award-winning cover of the Seattle Times investigative series about MRSA getting spread like wildfire at Harborview. That was actually old data. It was not accurate, but it was emotionally wrenching. And so the state said every patient at Harborview and every ICU in the state must have surveillance for MRSA. This was our bitter lemons, but we decided to make lemonade and start looking at these issues. So we actually can use this information for good. Lily, you're correct. I mean, somebody's going to be in that 5%, right? So if you have a strong sense that your patient could still have MRSA based on a prior history of MRSA, based on epi risk factors, especially people living and struggling with opiate use disorders and injection practices, you might consider continuing vancomycin beyond the initial empirical course. But generally speaking, MRSA pneumonia is very rare in our hospital, and it's hyper rare in people with a negative swab. Same too with Legionella. That was another nice question from Ruth. So Legionella pneumonia is uncommon. We have had issues with Legionella pneumonia, as has every other hospital in the country, because of concerns with our water supply. So the water supply in the city, some of you are not from Seattle. Seattle water is good water, and like water elsewhere in municipal situations, not well water, which is pure and amazing, and I wish we had that, but this is actually water from pipes. So pipe water tends to be contaminated with all kinds of microbes, not just human stool, E. coli, but also free-living germs like non-tuberculous mycobacteria, and in some cases, Legionella. Legionella in particular, it's an issue where there are areas of stagnant water, a cooling tower where there's dripping of water down, and then relatively warm water. Legionella is food for amoeba. So any place where there's amoeba eating Legionella, it can then get back somehow into the water supply. So we've struggled with this in our hospital system here at Montlake, where I practice especially, not necessarily with Legionella pneumophila, the one that we're all worried about, but with other non-pneumophila Legionellas as well. There are other Legionellas. Legionella mcdadii, for example, is one that's there. So our concern for this has been high in the past, and for that reason we have a huge remediation process whereby we're constantly surveilling the water. The water is carefully filtered and also hyperchlorinated. So what you will see, even today, in some areas of our hospital are filters that are right at the point of care. In one of our towers here, the main tower where you'd be on for medicine A, medicine B, and such, you'll sometimes see these little cassette filters. That's because we continuously are looking for this germ. So to answer your question, we've struggled with Legionella in the past. I think our water supply currently is really excellent within the hospital. Where we tend to see Legionella is community acquired. So if your patient is being admitted with community acquired pneumonia, but the pattern looks atypical, you're not convinced that it's COVID because they have multiple negative COVID tests, and it's not looking like other community acquired viral infections, thinking about so-called atypical agents, including Legionella, yes, I would absolutely keep that on the list, and I would not hesitate to have that person on atypical coverage. The lesson nationally in my opinion, is that we overuse atypical coverage in CAP. For CAP, I think most CAP is going to be pneumococcal or related to Haemophilus or some other non-atypical, well, it's the typical agents. So we are probably overusing azithromycin by a large margin nationwide. And yet it remains our guidance that at the time of admission, you should give patients both ceftriaxone and azithromycin. My prediction over the next couple of years is that the azithromycin will be demoted to becoming optional and really more discretionary with respect to your care. Furthermore, if you diagnose the patient with pneumococcal pneumonia based on a urinary antigen, based on their sputum culture, blood culture, no hesitation. Stop the azithromycin on the spot. Continue with your beta-lactam. That's your workhorse. That's what you're going to need for most of these cases. But again, for acquired infection within the hospital, again, very, very uncommon. Yes, we worry about enterics. We worry about gram negatives. We worry about Pseudomonas. That's what I want you to cover. And in fact, if you check our guidance for in-house acquired pneumonia, you'll see that it's cefepime. It really is cefepime to go after the gram negatives, to go after pneumococcus. We do not typically cover for atypicals within the hospital. Okay, how do I feel about mini BALs and induced sputa? Thanks, Rigo. Identifying causative organisms predictive for infection. Are they reliable compared to a bronch? Yeah, we really love the mini BAL. And for those who don't know what Rigo's talking about, bronchoscopy. So if I have a patient with an undetermined etiology of their pneumonia, I really am a big fan of the fiber optic bronch because it will not only give me through lavage high quality quantitative or at least semi-quant data about the bug, but you can also see what's going on. There's blood in there, there's a Lego brick, there's a mushroom, there's a tumor, whatever the issue is. Sometimes we get fooled. So I'm a big fan of driving with our eyeballs into the lungs and seeing what's going on, but that's not always possible. And the reason it's not possible is that you may not have access to the bronchoscopist. This typically would happen in a nighttime situation. Nurse would call you with new onset of what appears to be HCAP at night. The fellow, for whatever reason, is not able to be there for you to do the bronch. Consider a mini BAL. We have a process whereby at least one RT, one respiratory therapist, is qualified and certified to do the mini BAL in every ICU and every shift at Montlake. Because what we want to do is to get you, yes, that higher quality information. If we compare mini BAL to what comes out of the trap, that stupid little clear cup that sits at the very bottom of the ventilator tube, I don't like that as much. I think you're going to get mixed flora. Now, it may also have Pseudomonas or something, but you're going to get a lot of oral shmoo. What you want is the down deep information. So Rigo, you're correct. You can ask the respiratory therapist if the patient meets criteria for mini BAL, and if so, to do that. This is a long flexible catheter. It's basically a DeLee cath, like you would stick down the nose of a newborn. That respiratory therapist, they don't even know what lung they're in, much less what lobe, right? So it is not guided the same way as bronch. I think the quality of a bronch specimen is superior. And yet this will be helpful to you in day 2 and 3 because you're going to start them empirically on antibiotics, right? You know how to do that. What you want to do is have an exit strategy. And until you get high quality micro, you're going to be stuck with cefepime for 7 days. And maybe that's what they need. And that's okay if they need that. But holy cow, what if it was just a stupid case of pneumococcus? You could go from cefepime to ceftriaxone. The mini BAL will help you to do that. Please understand, the criteria for mini BAL are more stringent than that for bronch. There's a lot of reasons why you would not do a mini BAL. The patient cannot be oxygenated. They may have recently had surgery. You don't want to stick the catheter through their anastomosis. So it's pretty rigorous, and probably the only time you do a mini is because you just don't have access to the fiber optic. But when you can, yes, I would certainly like that. And then for David, great question about back to the MRSA swab. Thanks. How long do we believe this to be true? So the reality is that the proof is in the pudding. We have this requirement I was telling you about. It's a weekly surveillance. So every 7 days, this patient will be resurveilled. And that's the data set, similar to the data set that we were looking about that Lily was talking about. So is it common for people to acquire MRSA colonization in our hospital? That's rare because you guys are so good with your super meticulous, the best hand hygiene. You got the cleanest hands in the West. And so you and the RT and the nurses and everybody should not be picking their nose and then touching the nose of this patient. So it's uncommon for us to find hospital-acquired MRSA colonization, but it can happen. When it does, I think it's probably auto-infection. The patient probably scratched their perineum and then picked their nose, or we just missed it the first time. I mean, it can happen. But yes, we do rely on this Q7-day information. That should be good enough. At least those are the studies that she was citing. Okay. Okay, that's pretty much it. Oh, prevention, VAP. Is there a bundle of best practices to prevent VAP? The answer is yes. So just start chucking them out there. What are the bundles of best practices that people are doing to prevent their VAP? This is nursing driven. You guys may not have seen this so much. Head of the bed at 30 or higher. Thanks, Sophie. It could be even more. If we could put them at 45 degrees, we'd love that. The patients hate it. And the nurses hate it because they get butt sores. But yeah, so head of bed that's higher. Yep, spontaneous breathing tube, spontaneous breathing trial every day, lightening their sedation. Really also excellent hand hygiene and sterile technique with the mouth, as Lily says, trying to debulk the crap that people are aspirating. Yes, around the cuff. No, the cuff is not perfect, so that happens. But also excellent hand hygiene with the respiratory therapists, who are the ones doing the suctioning. Because if they just put on a pair of purple gloves and go, that's not good enough. There needs to be good hand hygiene before handling and manipulating the airway. Finally, there's another tech which actually has been shown to be helpful, which is continuous suction just at the glottis, but those tubes are a bit more expensive. We don't always have them in place. Silver impregnated tubes, that has been shown to help in the short term, but they're very expensive, and the evidence is not there as good. And yeah, Andrea, I agree. Spontaneous breathing trials to see if we can get the tube out. Love that. Okay, thanks, guys. The last case, ooh, yeah, timing's pretty good. The last case that we had in the curriculum was this case of C. diff. And I just, we included a C. diff case, not only because it's common, but also because it's painful. And it really is the result of what we do to our patients. I want to be clear, community-acquired, spontaneous, immaculate conception of C. diff, I mean, it happens. We do have people who are just walking around downtown and they beshit themselves because they got the C. diff. It's very uncommon. Still today, even in 2021, usually C. difficile is related to antibiotic consumption. And sometimes it's as recently as a couple of months before. It does not have to be at that very moment. There are cases you'll read about for ocular drops of antibiotics that give C. diff, but generally speaking, it's us, it's you. It's the community of physicians giving antibiotics that leads to this perverse nuclear annihilation of the healthy microbiota within the gut. It kills off everything except for the Clostridium difficile. Difficult to treat. By the way, that's not why the name is called difficile. It's also difficult to cultivate, but I think it is C. diff. It's difficult to get up and see those patients at night because they're just so very painful. So we included that case in the curriculum as a reminder, as a caveat to you, that our decisions have consequences. I want to be clear that if we get it wrong with antibiotics, we will cause C. diff in our patients. That's usually related to overly broad and long spectrum. The classic is pip/tazo, because it kills off every last Bacteroides, I promise you. All the healthy, beautiful little anaerobes that are helping you digest your coffee right now, they are gone, and the Clostridium will move in. But the reality is we do this even if we're perfect with our antibiotics. If you are scrupulous, you're guideline-based, and you are beyond reproach, you will still cause C. diff. And I just want to put that out there. Remember, about maybe 25% of patients who receive antibiotics will complain of diarrhea. That's called antibiotic-associated diarrhea. We see this all the time. You'll see it in your ambulatory practice. Of all that antibiotic-associated diarrhea, maybe 10% is actually C. diff. So it's a small fraction of a large chunk, and that's why it will be part of your experience. And so in ambulatory care, I'm asking patients to call me if they get watery diarrhea more than 3 times per day. They're receiving antibiotics that I'm giving them for some other torturous reason. Abdominal pain, cramping, fever, nocturnal poops. Most people don't poop at night. If somebody's getting up at nighttime to use the restroom, they should call you about that. And if somebody has fecal soilage because they just can't retain the BM, that's all very abnormal. Again, that may still just be good old stupid antibiotic-associated diarrhea, but that's what I'm worried about C. diff. The same is true at home as it is in the hospital. Here's the problem. We have a hypersensitive test. It is so very good. Looking for DNA. It's a PCR-based test looking for C. diff. That's a problem. It's great because we won't miss a case. You're not going to miss C. diff. The negative predictive value is close to 99%. The problem is that about 10% of us running around the community right now are also colonized with toxigenic C. diff. If you think about it, that's how this usually happens. The patient's already colonized, we take away the competitive microbes, and then C. diff blows up. There's an alternative pathway. which is they are not colonized. They come to our hospital with a PE, and then we put our shit into their mouth, and they acquire C. diff from us. That happens if we aren't good with our hand hygiene, because of course alcohol will not kill these spores. We got to use good soap and water. So that is also another model for this to happen. But in either case, the issue is that if we just surveil everybody, you're going to find a lot of folks with asymptomatic colonization, just like the Foley catheter that we started out with. So again, diagnostic stewardship is key. I would not encourage you to test everybody with diarrhea for C. diff, because you will find it, and you will still have that deep soul-gnawing uncertainty. Is it really C. diff colitis or colonization? So again, if your nurse calls you, and they will, because they're excellent, they're going to say, hey, this person's having diarrhea, can I send a C. diff test? Find out more. Again, you want at least 3 stools within 24 hours. It should be profuse. You should examine that patient and find that it's not just some squirts per rectum, the rooster tail sign, but they're really having, yes, painful issues with respect to their bowel movements. And if that happens, please do send the test. The other thing that we find is that patients are receiving lactulose. You may notice that we have this big, ugly organ in the right upper quadrant. It's called the liver. It doesn't work well, so these patients get lactulose. That's going to give them the shits. And so you may give yourself this self-fulfilling prophecy, giving lactulose, testing for C. diff. That's also a false paradigm. So they should not be on laxatives. It should be at least 3 poops per day, and the patient should recently have received antibiotics. In that circumstance, please do test. Immediately put them onto enhanced enteric precautions, gown, gloves, soap, and flipping water, period. It's a very, very catchy germ. I don't want you to take this home to yourself, your loved ones. Keep it in the room. And then test, and trust that test. We usually will not even allow you to resend the test. Certainly if it's positive, there's no reason to retest, except in exotic circumstances. If it's negative, we usually don't even allow you to do that, because the negative predictive value is, again, about 98.5%. Somebody's got to be in that 1.5%. So if you have a very high suspicion, you can send the test again. Just call and talk with ID first, and we can make that happen. But typically speaking, that testing can be trusted in its negative form. We're getting close to the top of the hour, I think. So questions about that: liquid diarrhea, germs in the urine, bugs in the blood, lungs full of pus, anything like this. Oh, I'm going to put my email in here. It's not hard. It's abx@uw.edu, because you guys may want to have private conversations or whatever. I'm always happy to. My office is here at Montlake, and I'm almost always here, but we could also set up an appointment if you want to just come and talk about anything related to this. Ooh, I also run not only the stewardship program, but also the fellowship program. So if you're thinking about careers in ID, why the hell would you not at least think about it? Then come talk. I would love that. We have a great practice here. Dr. Seth Cohen is here, Abby Hussein. We love what we do. We would love to talk with you guys. An ID elective is a great choice for you. We have an ID clinic. There's actually an ID clinic block that's available. See patients at Madison Clinic. People living with HIV, go to VA, come here. It's a fun rotation as well. We'd love to have you guys on service. Gabby, anything else that I should have mentioned or things you want me to emphasize?
No, this is great. And thanks, Paul, for mixing it up this week. It's always nice to have a conversation instead of just a set of slides. So I'm sure that is much appreciated. And a great reinforcement of things that we have talked about in different forums, pulled into one place, and highlighting plurals that have not yet been discussed. So really appreciate that. I have posted both a link for the attendance for today, as well as our evaluations. Please do both if you have not yet already. And please don't hesitate to put questions in the chat for Dr. Pottinger. As you know, he is quite accessible and always loves chatting about ID related topics. So no question is too small. Let's see. Anything else? We will return next week for our regular scheduled program. We have Dr. Allison Goldberg with us next week, and we'll finish out the month the following week with Dr. Andrew Chang from the VA, who will be talking about an approach to chest pain. Let's see. Other thoughts, questions? And I'll open it up, turn it back over to Paul.
Okay, well, just thanks, guys, for your time and attention. things like this will come up. And again, if you have issues that arise that we didn't discuss today, et cetera, just let me know. I'm always happy to talk. Oh, yeah, there was one other thing. God, I almost forgot. Wearing my fellowship hat. So, calling ID, and I'll let you go in here in just 1 second. We love to hear from internal medicine on the ID consult service. It's great. It's just really fun for us to do, and we know that you're taking care of really complex patients. So, call us if the bug is weird, if there's a bad resistance profile. Pretty much any patient in this hospital on more than 2 antibiotics for more than 2 days, you basically need an ID consult, even if you don't need it, and if we just rubber stamp what you do. People living with opiate use disorders were really important part of that care cascade we're eager to do. Discharge planning, people who have IV antibiotic needs, how do we deal with this outpatient? That's our practice. So call us, but call us like voting, call us early and often. What the fellows really love is to be called early. And even if you are on rounds, your attending says, oh yeah, I agree, we should have an ID consult. If you don't mind, just break away quickly to do that consult. We're trying to make it so that with haiku, you can actually haiku to a service that doesn't yet exist. You have to haiku to a person. So if you know who the fellow is, you can haiku them right on the spot. Otherwise, doing it as a page at the moment is still the way to go. But early is key. The fellows just hate getting those calls late. You can call us late, it's fine. Just that you may not be able to have that patient seen on the same day. Yeah, consults before noon is good, and even before noon. Just on rounds, during rounds is great. Okay, thanks guys. I appreciate it a lot.